just because you didn't meet the exact criteria on that given day for a certain condition that this doctor was evaluating you for, clinician was evaluating you for, doesn't mean that you are not experiencing the things that you feel like you're experiencing. Welcome back, every bendy body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician helping you navigate Ehlers-Danlos syndromes, joint hypermobility, and complex chronic illness. Today, I'm joined by Dr. Dacre Knight, Medical Director of the UVA Health, EDS, and Hypermobility Disorders Center, which is proudly partnering with Bendy Bodies. In this episode, we will be talking about the first four letters of the MENS PMMS treatment algorithm for hypermobile EDS and HSD. So we will be talking about movement, education, nutrition, and sleep. As always, this podcast is for educational purposes only and is not a substitute for personalized medical advice. Be sure to stick around until the very end so you don't miss our special hypermobility hack. Let's get started. I am so excited to be back with Dr. Knight, and today we're going to be talking about treatment for EDS, HSD, for comorbidities like POTS and MCAS, and questions that we frequently get asked from our listeners. How are you doing today?
Doing great. And as always, very excited to be here to see what we've got in store.
Fantastic. And I think for the purposes of this conversation, because we could probably spend hours and hours discussing this, but we're just going to share some of our favorite tips or stories and things that we've found really to make a really significant difference for people. I think we should use the MENS PMMS framework, which is just one possible way of approaching somebody with these conditions that allows us to be thinking about movement, education, nutrition, sleep, psychosocial modalities, medications, and supplements. And just kind of, for me anyway, like helps me think of the different categories. So I'm not just thinking about medications, for example, or just thinking about nutrition. So is it okay with you if we kind of approach it in that fashion?
I think that's an excellent approach.
Great. So first, let's talk about movement. And I think this is so interesting because I actually just came back from a physical therapy conference. And of course, most of the attendees were physical therapists, and so many of them understand joint hypermobility and connective tissue disorders, I feel like, quite well. But there are so many people who struggle to find a physical therapist that can work with them. And, of course, when you are giving a talk on hypermobility, you usually have people in the audience who are attracted to that topic for a certain reason. So do you have tips that you share with patients for how they can find a physical therapist that might be a good fit, or somebody that would be more interested in working with them as somebody with EDS or HSD?
Yeah, this is a really good question because not only is it a question I get a lot, but it is so important to their care on an ongoing basis that's what we want to see. We want to see that they do have access to a physical therapist closer to home, someone that they can relate to, that they feel comfortable working with, and to provide ongoing care. And it's a little bit variable of how much they need. Is a lot of patients gain the knowledge and they're able to do some of those things on their own at home, which is just fine. But sometimes it's unpredictable when they're going to need to recheck with that physical therapist. So as far as my advice on finding the right one, there's a couple things, and it really surprises me how many physical therapists are already pretty knowledgeable about these conditions, and I would say of any specialty, they're probably, as a specialty, more knowledgeable than others, as far as, versus primary care or family medicine or internal medicine or rheumatology and so forth. Because I think they're really at the front lines. They're the ones seeing the hypermobility and the distress it causes and the injuries that can happen from it. So that's point number one is to rest assured that it is among those. It is probably one of the better ones to look for, someone who's got some knowledge. And then there are a lot of avenues. One, it is good if you can access someone who is fellowship trained in physical therapy. And, but as any specialty is, there are some who are very knowledgeable just by their own experience and by their own interest of self-educating and things like that. So it's not necessary that someone needs to be fellowship trained or have a doctorate or so on and so forth. But that is a good delineation at a broader level. Another is that there's various sites and resources that got directories and so forth. The EDS Society has a provider directory where they can take listings from. I know you and I are there, but they can take listings from anyone who volunteers their information. So that's good knowing that they've already kind of availed themselves to this population. It's not like, people are hunting them down and, trying to find out who's who. They've already listed themselves. So I think that's generally the takeaway. And then, last resort, word of mouth, really. And there's a lot of patients who get referred that way from, having connections with friends or family and maybe if they don't know, maybe the physical therapist that they do know would know of another physical therapist, and I've encountered that. So I've had patients reach out to physical therapists. I myself have reached out to a physical therapist, and if they don't feel comfortable treating EDS or hypermobility disorders, they may know who does because obviously they are closely working together.
And I appreciate what you said about somebody being local, because for me anyway, in my experience with physical therapy, if I can have somebody that actually can work with me one-on-one in person, I do prefer that over the virtual options, even though I know for some people that is the most practical option. Either they live in a really rural area or they just don't have access to somebody with the right skill set, so they're doing the virtual option. But for me, the hands-on is really helpful. And I actually should share that it was my physical therapist who first suggested that I might have EDS. I had been to, an orthopedic surgeon actually at Mayo. I was going to have transposition surgery of my ulnar nerve, and he measured my elbow hyperextension in both arms. And he said, "Oh, yeah, you have extreme," I think it was like 18 degrees or something like that. And at that time, I didn't know anything about EDS. This is when I was still working in the operating room. And he just commented on it and he said, "Oh, after the surgery, you're going to lose that hyperextension in your left elbow. But, that's no big deal." And then I had a PM&R doc who, more locally, who commented on my excessive range of motion in my cervical spine and my lumbar spine and a number of other places. But she also never said what that might mean. It was my physical therapist who, after a few sessions, said, you're, you have hypermobility in a lot of your joints, and this could actually be an important factor that's influencing your health. And I had never thought about that before. So physical therapists can really play an important role when it comes to these conditions.
Yeah, I totally agree. And I think as a whole, they are really underutilized. And I think the emphasis on what can be done, short of like what you're saying, short of surgery should really be upheld because surgery is always the last resort. And I remember we're just a year or two ago talking to my sister about it, and it's same thing, orthopedic issues, and she doesn't have hypermobility, but she, I think it was knee or hip pain, and she was looking at surgery, and no one had really brought up the topic of physical therapy for her at that point, and I brought it up, and lo and behold, yeah, she was able to work through those issues and didn't need surgery. Sometimes it is necessary, but I think it just, goes back to your point that, we really want to make an opportunity for care that can be delivered in the least invasive way, and then something that is potentially sustainable over a longer period of time.
And we're talking about this because, the first letter M stands for movement. Also, there are, of course, Pilates instructors and, gyrotonics, and people can take all kinds of different approaches to, working with a personal trainer or all kinds of other things besides physical therapy. But I think that physical therapy is such an important place to start. And I would love to know how you answer this question or this comment that at least I get a lot. So I figure you probably get it too. When people say physical therapy doesn't work for me, how do you handle that?
Oh, yes. Yes. And that is a common, common description. And the first answer is that, some physical therapy can truly be damaging if it's not done correctly. And that really pertains to who's doing it and what is their level of knowledge and understanding. And that makes a huge difference because, while I said that a lot more physical therapists than we may realize know about EDS and hypermobility disorders, there are some who still don't know and are not aware. And we would hate to see patients be pushed into therapy that is really just counterproductive, and it happens, unfortunately. So the counseling provided then is that, yeah, it's very unfortunate when it does happen, but do know that there is still opportunities for improvement yet to be had, and that's what's crucial. And so in our center, I know other sites and other clinicians like yourself have connected with physical therapists, like we're just talking about earlier, how to find the right physical therapist. But we have connected to those physical therapists, so we are confident in the care that they can provide, and we want to get patients to them as soon as possible.
Yeah, absolutely. I kind of forgot about one physical therapy session that I had where I really had a terrible flare afterwards. And the person spent like the whole time trying to increase the stretch in my hamstrings. And it was a while before I got back to my baseline. So I think the slow and low approach is appreciated by a lot of physical therapists, but maybe not all of them. So maybe even if you're young and you can walk into the office, the physical therapy office, and they might look at you and think, "Oh, you're 25 years old. Like, of course you can do these exercises." Maybe people can say to the physical therapist, "I know it might look like I would be capable of doing a lot, but can we start a little lower than usual?" If you feel like they aren't super knowledgeable about EDS and HSD.
Yeah, and the concerning thing about that too is that if someone has had a bad experience, then they are less inclined to try it again, right? Rightly so. And I hate to see that because it's a failed opportunity for improvement, and but no fault of their own. It's understandable why they would be cautious about approaching further therapy.
Yeah, definitely. And that's why when people say that to me, it doesn't work for me. I say, let's think about this as kind of dating, and you might have to date more than one person before you find the right one. Same thing with a mental health therapist. It might take you a few tries before you find the right one. And I also wanted to comment about just movement in general, because, of course, we're talking right now about movement guided by a professional, but we also should be thinking about movement that we're just doing on our own. So whether it's we're walking around the house, walking around our neighborhood, taking the dog for a walk, I'm sure you've seen this where both over resting and over pushing can both cause problems. Do you have advice for people about that?
Yeah, that couldn't be more true. And so that's why we say on an individual level, we really have to approach it to understand what's the capacity of someone, what are their goals really, and what do we expect them to achieve. And we do have to be mindful of it. While, yes, I mean, it's pretty clear we're talking about physical therapy and exercise and all of that, then we are avoiding the deconditioning, the rest part too much, and, although it is crucial. But the physical therapy itself, we have to approach that in the lens of well, as we would say from our Hippocratic oath, first do no harm. So it's going to be totally useless if the only thing they're getting from it is pain and suffering. So we do have to approach it very slowly and carefully. And really, I mean, in this way, exercise itself has gotten it has become a bad word in this field because uh, we don't want to think of it as, or even the message being to patients that you just get out and just start running and, everything's all better, right? It's because it's not. And likely there has been enough injury and deconditioning that you can potentially re-injure yourself very easily if it's not done carefully. So we talk about a joint protection program when we approach physical therapy and movement. And that's simply just knowing what your joints can do and what they cannot do. And then finally, those things that you can do that you should do to prevent further injury. And so that's the real basis of it. But it does have to be approached very carefully.
And I think it also helps knowing yourself, because knowing if you're somebody who needs a little bit more encouragement, needs to be pushed a little bit, or are you somebody that needs to be held back? When I'm talking to a patient, that's one of the things that I'm really trying to figure out. where they are in that spectrum, because there are people who are definitely doing too much and paying for it later on a really consistent basis, and other people who, should be trying to push the envelope a little bit more.
Yeah, that's exactly right. And I think back the specific scenario in this case. I had a 34-year-old patient, so very active, younger professional who had been high achieving and very athletic through her life. And over a span of just 2 years prior to her seeing me, she felt like her life had just completely unraveled because, she was having the symptoms of what we now know to be HEDS. And it started with brain fog and then more exercise intolerance. She was someone who liked to continue doing her exercise that she had brought into her early adulthood from her adolescent years. And then she developed some of the autonomic dysfunction and things like that. And really what, was striking to me is that, a lot of patients and understandably may just kind of stop right there. And that's how I think there's one pathway that's taken. And this patient had done all the standard things, had gone and seen her primary care doctor and did the usual run of the mill lab testing exams, and was told that his stress and burnout and other somatic type of symptoms. And so what she did is, and I see this a lot, and I'm sure you do too, she ultimately internalized her symptoms, right? And she just kind of thought it was upon herself to push harder, really, and push against this force that was pushing against her. And so she just went at it more aggressively. She was telling me the details of how her workout plans she just didn't quite double them, but tried to put in more time, ultimately time and sweat into her workouts, and was ignoring her body. And what we always tell our patients is, try to go with your gut and do pay attention to what the symptoms are and how they're evolving. But unsurprisingly, she got worse, and she just got to the point that she just couldn't exercise anymore at all. And then that's where obviously the symptoms pick up, multiple folds. And there's, at that point, it's a lot more difficult than if we can catch it sooner. So, by the time I saw her and did all of the evaluations that were needed, and were otherwise, just not done, not in the care place that they could be done. And so, once we got that redirected to having a little bit more understanding of, autonomic dysfunction and how to, balance that with hydration, pacing specifically, and then other, physical therapy skills that she could bring into it, and ultimately, her function did improve. It first stabilized, and then we did find some improvement after another year. And so, and what I was hearing from her at some of those follow-up visits is that the way she was describing is that she wasn't getting sicker because she was weak or just because she was not exercising enough. She was getting weaker and more symptomatic because she was following advice that she thought would be for the normal person, right? For the general population, where you just, you had a rough couple days and you rest up and then you go at it even harder to try to rebuild your level of energy and your function. And we know that patients with HEDS and HSD are a different category from the general population, which is why we even talking about physical therapy, why in the wrong approach, it can do harm.
Yeah, definitely. And what about POTS? Do you have different advice that you give people regarding exercise or movement with POTS?
Yeah, that's a very good question, because if we don't recognize it ourselves, the patients will recognize it very quickly that the standard
Mhm.
exercises are not well suited to them. And as we know, these orthostatic symptoms, meaning like symptoms when you're upright or standing for prolonged periods of time, make it all worse. Then we have to think about things that we can do in a position that's not requiring them to stand up for so long, or kind of the up and down repeated movements.
Mhm.
So let's just take like recumbent bicycle as an example, and that's talked about a lot. But there's other ways to do that, but that's generally the approach. So
Mhm.
you're getting good lower extremity resistance exercise, but you're in a position, seated or closer to seated, lying down, so you have better distribution of your circulatory system, and that does help patients a lot.
I have a patient who has POTS who thought, well, I would never be able to do a rowing machine, even though rowing is also a seated exercise, right? But that person worked with a personal trainer a little bit, and the personal trainer taught them the proper form for using a rowing machine. And now they're able to do it quite regularly without flaring up back pain or anything. So that's good.
Yeah, and it's it's all part of our job, right? To reassure patients that that there may be things that can to still help, and so it's a tricky balance from what they experience to trying to encourage and to get and find the right path and get them on it.
But we all need to move. So that's that's why out of the three M's, movement is the first one. So we're going to move on to the next letter, E, for education. And I feel like, this is something that maybe a lot of people don't really appreciate because, of course, physical therapy is one of the first things that a lot of people are prescribed if they are suspected of having EDS. But I found myself when I understood about central sensitization, for example, and catastrophization, and realized that I was doing that to myself and that that was making my pain worse, it really helped me a lot to really understand that and that I wasn't imagining things. I wasn't creating the pain in my head, but at the same time, like I was feeling it. That's where we feel everything, right? Is in our head and our brain. So how do you educate people about things like central sensitization? Because these are really difficult topics to broach for sure.
Well, it is, and it's especially difficult in any medical topic when these may feel contrived, like the doctor just pulled this out of his hat and he's just just making something up just to try to make me feel better or just convince me, one thing or another. And I would say in the early years of understanding central sensitization that it was very much theoretical, and wouldn't go so far as to say contrived, but at some point someone had to kind of map it out in their brain that this may be something going on. But what we do have to benefit us now more so is more evidence and data showing from laboratory studies that there are some objective measures of this type of pain and pain conditioning, what we relate to like nociplastic pain. And so I know we've gone through that in a recent episode, but to go through that a little bit further when it comes to the patient is that I think it's reassuring to them to know that okay, it's not one specific injury that has caused this, because otherwise they would be told, well, what did you do? I didn't do anything. It's the pain is there. And it's not just one specific imaging finding that's going to identify it either. So your MRI looked great, your X-rays are normal, and that's the message. And so those are the situations where patients may have developed some doubt about it because they've seen providers that were describing as such. So we have to go through and explain the process and the mechanisms. And I know there's no one better here than you, Dr. Bluestein, to explain that. But that's I think that's the course it takes for me.
Yeah, definitely. And I should have probably defined central sensitization before using it in this context. But we know that pain is one thing and damage is another thing, and they don't always correlate. And sometimes the problem that lies actually in like the software of the body and how it processes pain signals. So we can be having pain in parts of our body that we don't necessarily feel, and we can have pain even though there's not damage in that part of the body. So I found that to be so helpful when I saw a YouTube video by Dr. Dan Claw. That was really, truly like the beginning of a complete 180 in terms of my health and my problems. It just made all the difference in the world to understand those concepts.
Yeah, and I learn a lot from so many others too. And I've had a pain psychologist illustrate it in a pretty good way for me to grasp it as well. And I think, yeah, I think the more we have a better grasp of it, then we can employ some tools to help control it. But the way she's describing it is that there is, yes, this central processing of pain that takes place, obviously. And it can be amplified or it can be diminished. It can be a volume adjuster, if you will. And the analogy she would use is, in Vietnam or some battlefield, and someone got their leg shot out, or stepped over an IED or grenade or whatever. The first hour afterwards, they may not feel any pain, and they come to the field hospital, and I saw this firsthand. I was working at a combat trauma hospital in Afghanistan, and they just have no awareness, really. And we would look at them like, oh my gosh, how are you still alive? But they're just kind of in this stupor, of course, in shock. But otherwise, pain is not the thing that's registering. And so an hour after they've been sitting there, they kind of take in their surroundings. Then it just really hits them all at once. It's just a flood. And it's just like, of course, it's just like, life-ending pain. And it's just the worst thing imaginable. But there's that period there that it's not even been processed. And alternatively, there are other situations where, again, like we said, there may not even be an injury. It may just be, someone carrying out their daily activities, and yet the pain is there and it has been amplified. And we're still learning a lot about it. But like I said, I'm glad to know that we do have some objective data to rest on. So in the lab, we can compare patients who have these conditions, understand their response to pain, just like how you mentioned, from a certain stimulus, like a stimulus that is not meant to cause pain to the normal person, but to someone that has central sensitization is applied to, they report pain. So we can take those things in the lab and we can objectively measure them now better. But it's just, I think, opening doors to us to have a better understanding. I mean, whether it's like, we talk about mind-body therapy and other meditative type of practices. I know they do this in your field of anesthesiology and trying to control pain through meditation. And some certainly are better than others at it. But it's a tool that, I mean, could you imagine? Wow, someone's able to capture that and control it. Then that's, I mean, huge. Rather than having to rely on opioids and other things.
Well, I think that was also another pivotal point for me. I was at a wedding and I was sitting next to a pain psychologist, and he was talking to me about hypnosis. That time I had a lot of pain in my back, and I was having a lot of sciatica type pain, and it turned out it was, probably from the Tarlov cyst. But he suggested that I come see him formally in the office so that he could hypnotize me. And when he hypnotized me, I felt no pain whatsoever. And that really helped me to realize, wow, the mind is very powerful. And while we don't want to gaslight people and say, well, just think your way out of your pain, we also can make our pain worse or better by what we think and what we feel and how we feel in our nervous system. So if our nervous system, for example, doesn't feel safe, that also will amplify our pain. So using those kinds of tools, I think, can be really helpful.
Yeah, it really takes buy-in from the patient, right? They really have to believe that it is possible, or else it won't even be tried. And I think that's our role as providers, is to, yeah, just like you said, counsel them carefully. So we're not giving a message that is in your head and, just think your way through it. But there are resources yet to be explored that can certainly be beneficial and low cost and very low side effects, if anything at all. I mean, we're talking about hypnosis or meditation, there no side effects, or maybe only beneficial side effects. So I think that's what it's all about.
And another component of education to me is helping people understand the importance of balancing the dose of information that you get. Like nowadays, we really need to balance the dose of the news that we get, because that, obviously, speaking of your nervous system being more activated, that'll do it, right? So do you give people advice about this? Because of course we can all fall into these rabbit holes, right? Where we're just reading more and more about things. And I encourage people to really think about how much time they're spending doing those things and how much time they're spending doing things that they really enjoy and really love, and trying to incorporate those things back in their lives. But are there any other tips when it comes to education like that you want people to know about?
Well, it is, and I mean, it is important, and it is also, I think, so important and something that has to be done so carefully that it's often left in the hands of a pain psychologist because it takes time to understand the concept. It's not easily just a short visit just to kind of describe all the pain processing and the pain behaviors, because there is a lot of that goes on, and you mentioned the news, but not only the news, social media, and other avenues that can be stress inducing, that can lead someone into recapitulating pain behaviors that others are doing, or they themselves might not even know what they're doing. So, pain behaviors in this sense is are activities and actions that uh, remind someone of their condition and of the pain that they felt. And let's use an example like sometimes ergonomics or bracing or certain things that we do in our daily life to avoid pain. They in some ways, yes, if they're helpful, that's fine. If you need a brace, that's fine. But as soon as you don't need those things, move them aside, because that's a reminder potentially of there being a pain limitation, and then therefore it's almost like a self-fulfilling prophecy. And then the 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 idea of having pain then begets pain. And so, this is very tricky. Like I said, it's often better done in the setting with a pain psychologist, because they can answer all the questions and kind of go through everyone's specific situation, which is obviously unique. And I'm not doing any justice to the very complex nature of HEDS and HSD related to pain in anyone's specific life. But I think, yeah, here to your purpose of your question, I think that it's just that idea that there are external environmental influences on pain as well, not just things within us.
And I'm so glad that you mentioned about pain begets pain, because I'm trying to remember what it was. Something happened with me recently. That's good, I guess, in a way that I can't remember what it was, but it was something acute. Oh, I know. I was playing pickleball, which I never thought I could ever play pickleball, but I was playing pickleball and I felt a sudden sharp pain in my quad. And I think I probably, had a small muscle tear or something like that. And fortunately, it healed up pretty quickly within a period of a few days. But the interesting thing about that was everything else in my body started to hurt. All of the like little lingering things, I have kind of some things with my shoulders and with my knees and my feet, all of which were, you know, managing very well controlled. But then when I got this injury to my quad, which wasn't that big of a deal, but it was a new acute pain, I suddenly started feeling all of these other pains in my body. So I'm glad you said about the pain begets pain, because I think it's an important concept for people to understand and realize that if we can affect one area of a person's pain, oftentimes that can influence how their whole body feels. So even though we might not have the ability to, like you said, we're going to avoid surgery if we can. So we're not going to operate on your right knee, your left foot, your left elbow, if we don't have to. But by fixing or improving the pain in one of those areas, we might actually improve the pain in the other areas.
That's exactly right. And that's been my experience as well. And I think the real approach, the best approach here is having the patient direct their own adjustments to their pain behaviors and to their goals of pain relief. And we can certainly provide education support as we do as clinicians, but the importance of that buy-in from the patient, and letting them lead and direct their goals and how to get there, I think is the most important part of it, because there certainly is history of kind of the paternalistic approach to medicine. It's like, well, you're having pain, then you stop doing this, and it's like their lives and their conditions and their symptoms are so nuanced individually that we have to let them explore that themselves. And I think that we hear about coaching as part of counseling, and health coaching, and even career coaches do this. They identify or let the individual identify what their own goals are and then help them shape their own direction to reach that goal. And I think that's the best case when we're talking about these approaches to managing pain, because everyone's experience is so different.
That's a great point of letting the person guide it themselves. I think that's great. We are going to take a quick break, and when we come back, we are going to talk about nutrition and sleep and some of our other favorite tips for navigating people with EDS and HSD and all of their various different symptoms that people are managing with. So we will be right back. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. So we're back with Dr. Dacre Knight and talking about some of the elements of the MENS PMMS strategy for managing symptoms related to hypermobile EDS, HSD, and comorbidities. So next, let's talk about the letter N, which stands for nutrition. And we know that nutrition is super important with these conditions, but the tricky thing is there's no one-size-fits-all approach. How do you navigate this topic?
Well, it does come with a lot of a multitude of considerations based on, first, I would say comorbidities, and certainly gastrointestinal comorbidities are high on the list there as far as nutritional issues can be, and malnutrition and nutrient absorption. And so I think that's the first place that we want to start. And then dependent on what other underlying medical issues may be. So not just like comorbidities like POTS or dysautonomic or mast cell, but if they do have any other comorbidities, think of, anemia, iron deficiency, things like that, then those also have to be high on the list. Mast cell activations would be close up there with general gastrointestinal concerns too, because those can be affected so much by the diet.
Yeah, and it's tricky because a lot of foods that are generally anti-inflammatory are not necessarily good for people with mast cell activation syndrome. So that can be really, really tricky. So I do recommend when possible that people work with a dietitian, but not everyone can do that, of course. But like you said, I'm glad you said this about, some people are actually undernourished and underweight, and other people are, really struggling with, well, I'm not actually eating that much, but I tend to retain water or, feel like I'm gaining weight for no obvious reason. So I've seen people write on social media that, well, my doctor just told me that I'm in pain because I'm fat, which is, of course, a terrible thing. So have you heard patients describe that when they've seen other clinicians?
Oh, of course. Yeah. We talk about pain and joint related pain. And historically, that's what some of these studies have shown in things like osteoarthritis and, just generalized joint problems. It can be influenced by that. But the problem here is when we talk about nutrition and diet and weight is that, and is that getting all of those things on this right playing field as far as what we do to avoid malnutrition, to avoid further joint injury and things like that. That's why we have to get it right. But I would also say that, in my experience, the patients who really are in the worst condition and have the worst outcomes and sometimes very tragic outcomes are those who have severe nutritional dependency. And because that's a very slippery slope. Once you start losing or once you start having worsening malnutrition, then it's so hard to regain because so many organ systems depend on all of the nutrients you can absorb from your gut. And then oftentimes patients, get to such a difficult state that requiring feeding tubes or TPN, which is just artificial nutrition through their the venous system. And we want to avoid that. We want to get them off that as soon as we can because it can progress quite quickly.
I've definitely seen that as well. I've seen fairly young patients that are, like you said, they're maybe on TPN, which, all your nutrition then is coming in through your veins, and there's no perfect substitute for actual whole food. And then you're not using your gut, which also causes its own set of problems. So yeah, I agree. I think thinking about food in terms of all of the wonderful things that we need to get from our foods, there are the macronutrients, the protein, carbs, and fat, but also all the micronutrients, all the different vitamins and minerals and all of those kind of things. Because I think what happens, at least in a lot of the patients that I see, they feel like, okay, I think I reacted to this particular food, so I'm going to eliminate that. Then I think I reacted to a different food. I'm going to eliminate that. And next thing you know, a lot of foods have been eliminated. And potentially with that comes a lot of different nutrients that are critical for maintaining the tissues in our body. And our tissues are in a constant state of reformation, right? So we need all of those elements in order to build the best possible tissues. I mean, even if our genetics are such that we're not building, you know, the most ideal connective tissue, we at least need to be supplying those nutrients so that we're able to do the best possible job.
Well, that's exactly right. And I rely so heavily on my nutritionist colleagues and dietitians because of that, because that's exactly the scenario. And if there's not a stop put to it, then it does just progress to feeding tubes and TPN. And so we need to get nutrition support involved early and quickly. And I would say that, going back to the question about, weight and patients being told obese is the cause, I would say really the weight and obesity is a non-issue for the vast majority of patients with HEDS and HSD. And that's to say a non-issue in the sense that not likely the primary contribution. Okay. We just started a research study on BMI and HEDS and HSD, and we're coming across some interesting findings, which will be published in the near future. Because this gets talked about a lot, and it certainly gets talked about now in the case where we have Ozempic and these other GLP-1 agonists that are out there and available, and maybe beneficial too. So we want to be able to capitalize on those if there is some benefit for our patients. But we just want to a little bit learn more about the effect of BMI or cause and effect. It's hard to do these studies to really know the causal relationship because, for example, like you said, obesity has been attributed to the cause of joint pains. Uh, we don't think that's the case in these hypermobility disorders. We think that the joint pains are influenced by so many other things related to joint instability and injuries that had been taking place, and there's all these other central sensitization effects that we're describing. But there may certainly be an effect of obesity where then the pain has caused deconditioning and has caused otherwise poor activities and less physical activity and the GI issues have caused malnutrition. So patients are having to rely on simple carbohydrates and things like that can add weight. But there are also what we're seeing from our data. There are also subgroups of patients that kind of fit into these areas more than others, and we're still learning more about that. Of the patients who have pain that have normal or low BMI, and compared to those who have higher BMI, comparisons and differences between those.
I'm glad you brought up about GLP-1 medications because there are different, like you said, there's Ozempic or semaglutide, tirzepatide, so many different ones. But these actually can be helpful for stabilizing mast cells. And I never thought I would prescribe these medications, but I do prescribe them in very low dose, even for normal weight patients. And a lot of patients have found them to be very beneficial. I heard somebody the other day, or I saw in a group that you and I both belong to, where people were actually talking about these GLP-1 medications and saying that they were more like weight normalizing drugs because in some people, actually, it helped them enough that they would, actually be able to gain weight if they were underweight. Have you ever prescribed a GLP-1 to somebody who's underweight or normal weight? And if so, what was that like?
Yeah, so just very recently, and because as you pointed out, these are all very new things, and it is very exciting to see some of the first throughput of data on these cases. And so, what was it like? I mean, it's always very satisfying to see improvement, and any tool that we can find that will bring that to us, as long as it's safe. And we do know that, yes, there's potential side effects, GI disturbance and nausea and things like that can come with these GLP-1 agonists. Uh, but if tolerated, and it's pretty early on enough in the course that someone would know if they can tolerate it or not. Uh, but if tolerated and it's providing relief to, whether it's mast activation or other cardiovascular, or glucose control things, then that's great. And the difference is that, yes, for the normal weight individuals, it's a small dose, or what may be a microdose, as it's called, these GLP-1 agonists. And so also to benefit, maybe the side effects are more easily tolerated, but some of the benefits can still be achieved.
And what about gastroparesis? Do you see that a lot in your patients? And if so, do you consider that an absolute contraindication to GLP-1, or you just go even lower and go even slower? Or what are your thoughts about that? Because as you said, that's exactly what I've seen is the patients who really struggle with nutrition that can end up, spiraling into a really bad situation quite quickly.
Yeah. So, first off, I think we should say that GLP-1 agonists may certainly not be the first go-to, right? And we may try lots of things at first, and we should try other things. I would say first before we do any medications, any pharmacologic intervention. We should do all that we can as far as diet and nutrition, and kind of all the standard courses, and probably in the case of most patients with HEDS and HSD, get them to a nutritionist before we consider these, because there are so many things that can affect the GI system and symptoms related to nutrition, those we're just describing, that a nutritionist may help. And it's just kind of like we're talking about physical therapy, how we can, maybe hope to avoid surgery. Same thing. Maybe a nutritionist can help us avoid medications. And so I think your first part, do I see a lot of gastroparesis? So, um, yes, I see more gastroparesis in our population than I would otherwise in the general population, and I think that's been laid bare through the data and available literature on that. But it was what has also been laid bare in the literature is that gastroparesis may not be as common as we think initially. There can be symptoms of gastroparesis without, kind of like how we talk about POTS and dysautonomia, right? And there's some specific criteria for gastroparesis. And so even if it doesn't meet clinical criteria for gastroparesis, how long the food's sitting in the stomach before it's passed on a gastric emptying study, there can be symptoms of gastroparesis, which we would relate to, kind of like how we have POTS and then we have autonomic dysfunction or orthostatic intolerance on a broader level, or we have HEDS specifically, where we have hypermobility spectrum disorders on a broader level. We have gastroparesis, and then we have disorders of the gut-brain interaction on a broader level too. So these disorders of the gut-brain interaction can include postprandial distress, which is a mimic of gastroparesis. And so this is the nausea, this is the bloating, this is the discomfort that comes with it. Functional dyspepsia. There's a very good write-up for any clinician out there in the New England Journal of Medicine just past month. A very good review by a colleague at Mayo Clinic in Arizona. But so going back to your question, yes, if those things are already present, we certainly have to be wary about GLP-1 agonists, because we talked about the side effects of those being nausea primarily and gastrointestinal disturbance. So that's especially in the case where we're having full dose of Ozempic, for example, for weight loss. In the cases of the microdosing for mast activation and things like that, I think we do have a little bit more of a wiggle room because these are smaller doses. But yes, we are very correct to be thinking about those in anticipation of what the issues the patient might have if we prescribe that.
I love what you said, and I want to just highlight this for a minute because I think it was really important. So you pointed out that POTS has very specific criteria, which a person may or may not meet, but they are on the spectrum of dysautonomia or dysfunction of their autonomic nervous system. if they go to see a cardiologist or a neurologist and are told, well, you don't have POTS because your heart rate didn't go up by 30 beats per minute or 40 beats per minute if you're, a teenager or younger. I think that this is such an important to use that as an example. And then also like postprandial distress versus gastroparesis. So often people go to the doctor and they say, well, you don't have hypermobile EDS. So, or you don't have POTS. So then the person is left thinking, oh, I'm just imagining things, or I'm just a wimp, or whatever it might be. But your point is we have very specific criteria for the diagnosis of gastroparesis or delayed gastric emptying. But on a bigger scale, we have postprandial distress, which is a very real thing. Dysautonomia is a very real thing. HSD, of course, is a very real thing. So I think that this is just an important concept for people to understand, that just because you didn't meet the exact criteria on that given day for a certain condition that this doctor was evaluating you for, clinician was evaluating you for, doesn't mean that you are not experiencing the things that you feel like you're experiencing. I mean, I've been diagnosed with functional GI problems in the past. Unfortunately, I don't have any of those problems now. But I remember when I was told, oh, well, I don't think it was functional dyspepsia. I think it was something maybe a little bit different, but I was having all kinds of problems with like swallowing hot and cold liquids and other symptoms. And when they told me functional, I thought, oh, you're saying it's in my head. So I just think it's important for people to understand that, we have to have very specific criteria for certain, specific diagnoses. But, you know your own body, you know what you're feeling, and that doesn't mean that you're not having a problem in that realm. It's just maybe you don't meet the exact criteria for something like POTS.
It is 100%. And I would say that all of those criteria we just reviewed, none of those criteria are symptoms of a condition that someone's feeling. If your symptoms are there, they're there, whether someone can say that or not. There's only one person who can say that. And so that's what you need to take in mind. And we are here in the business of helping people. If they are telling us that they're having symptoms, then we need to help them. Okay, whatever the criteria is, whatever the criteria says.
Yeah, good way to put it. Okay, so we're going to talk about sleep as our last topic for today, and then we're going to come back on our next episode to discuss the last four letters of the MENS PMMS acronym. So sleep, we know, is such a challenging thing when people are in pain. There's the term painsomnia that people use. So, you have pain, so then it makes it hard to sleep, and then you don't sleep well, which makes your pain worse. And you can end up in such a vicious cycle when it comes to sleep and sleep disorders. And it could be falling asleep, staying asleep, or waking up too early, or all three of those. We know that sleep apnea is more common in people with EDS and HSD. How do you approach sleep when it comes to working with your patients?
Well, sleep is crucial, and it cannot be emphasized enough that if patients are not getting restorative sleep, then, and I think you've described this very well in other episodes too, if we leave any one comorbidity or complication unaddressed, then we cannot expect to have full resolution of any other complication or comorbidity that may be present. And sleep is so much complicated by the issues and symptoms of HEDS and HSD. You name some of them, sleep apnea. But let's just take pain, for example, which is a very obvious one. If someone is in pain, and we've gone through autonomic dysfunction before, we've talked about this sympathetic and parasympathetic response, and pain being a trigger for the sympathetic response, which is our fight or flight response. If someone is in pain and you're in a fight or flight response, by definition, you are not in a restful state. And that pain can happen in the middle of the night. It can happen when you're trying to go to sleep. And we like to employ our occupational therapy colleagues in these cases where the patient is in a really bad state as far as, anything that can help, whether it's mattresses and pillows and adjustment and sleep hygiene and so on and so forth. But it's kind of a double-edged sword, because we need to do those things to help sleep. And also in return, if sleep is not good as it can be, those things will also be made worse. As far as pain goes and the stress response and all of those things that we talked about. And so it's crucial is the short answer.
Yeah, it is crucial. I mean, so many important things happen in our brain and in our nervous system when we're sleeping, right? And it can be so challenging for people. Do you ever write prescriptions for some of the sleep medications, or because I know like benzodiazepines, for example, can actually be helpful for people with mast cell activation disorder, but also at the same time, like these are medications that can be highly addictive, but some people find them helpful for their sleep. I feel like this is a really tricky topic in terms of, of course, there's supplements that we'll talk about next time too, for that can be used for helping sleep. But do you ever write for those kind of medications, or not really?
That is interesting, and what's interesting about it is that I find most often patients are already on those medications by the time they
Right,
come and see me.
right.
And so usually the answer is no, I don't have to because they're already on it. So then my role thereby is then trying to get them off it if possible. It may not be possible, but if it's the first time they've seen someone who's knowledgeable about HEDS and HSD, then hopefully we can make progress on those sleep disruptors, whether it's pain or autonomic disturbance or this stress and sympathetic response. So we have a lot of work to do usually when someone comes in, but likely they are already on those medications at that point.
Do you find beta blockers taken in the evening to be very helpful for people with POTS?
Well, sure, and really anything that we can do to help POTS at all is helpful, and and that may be medications. It may be they were talking about the physical activity earlier. We know that physical activity from multiple studies improves sleep because it helps implement that circadian rhythm, this sleep wake cycle it is so dependent for patients, um, and it also you know it also is important that with this physical activity that we're recognizing that they're active during the days. Now, of course, there may be limitations with fatigue and things like that, so we don't want to overdo it. I think this is we've got to strike a very careful balance here. But there is something that is called sleep inertia, and this is what we develop over the day from the time we wake up until the time we go to sleep, and that's dependent on what are the activities that we're doing during the day. And so there's been discussions about napping or not napping. I would say that's still in our population, it's still on an individual level. For the general population, as a sleep doctor or sleep specialist might say, avoid naps to help improve your sleep inertia, to get to the point where you will feel more tired when the time comes to be tired. But we are complicated with lots of other things that can cause fatigue, and so if napping is necessary, it's not the end of the world. We just have to go by it on an individual basis.
And I'm glad you brought up about the circadian rhythm because that is something that, definitely I see disturbed in a lot of people. So they'll be going to bed at 4 in the morning or 5 in the morning, and getting up in the afternoon. So instead of being asleep when it's dark out and being awake when it's light out, they're almost doing the reverse. And of course, there are shift workers that do that by necessity, right? But we know that that's not good for our bodies, and shift workers can have more inflammatory conditions like diabetes and obesity, heart disease, strokes, etc. So, do you see this very often in your patients, people who have like a flipped circadian cycle, or is that something that you don't really see?
No, I do. And I can just recount to a patient I'd seen very recently, just a couple weeks ago, who said to me that she is awake all night and she sleeps during the day simply for the reason that when she's awake at night, there's less environmental things that she's sensitive to, whether it's sound, whether it's light or whatever disturbances. Obviously not ideal because yes, we have studied workers who are on the graveyard shift, and we know that their long-term health issues are compromised because of that. But I mean, to answer your question, yes, I've seen it. I've seen that as a patient who had just had to quit her job and move back into the house with family, and and quit her job because she couldn't keep up with it for the medical issues she was sustaining. But then to support herself, she moved back in with the family, but the family is in the house and they're disruptive and they're bothersome as some of our families could be. And so she just decided that, she's better off by staying awake at night. And I don't recommend it, but I do understand and I can sympathize with those situations that arise. And I outlined my goals for her that we want to improve her medical condition so that, not only can she one day get back to work, but at least one day get back to living on her own and living back on a normal sleep wake day night schedule.
Yeah, and I know there are some people who can function really well with, a flipped cycle like that. And if somebody's doing great, then I probably personally would just leave it alone. But of course, if they're coming to see me or they're coming to see you, they're probably coming to see us because they're not doing well, right? So, if I happen to be talking to somebody, a friend or something, and they're like, "Oh yeah, no, I sleep during the day and I'm awake at night," I'd be like, "Oh, okay, fine." But I think it's definitely something that can be, really impactful if we can make a difference with that. I had a patient once who was literally going to bed at 6 a.m. every day.
Yeah.
So,
Yeah. Oh, yeah, I see it. And at that point, I mean, we certainly go through, we want to reemphasize all the good sleep hygiene principles. So, going to bed the same time every day, waking up the same time, getting some physical activity in, avoid caffeinated drinks late in the day, alcoholic drinks. Don't go to bed too full or too thirsty, and avoid distractions in the bedroom, and don't use the bed for anything other than intimacy or sleep. And our patients usually have done all of those things, I would say, just like, when we encounter pain, they usually tried a lot of the run of the mill things. So we have to think outside the box. But those are core principles always to keep in mind.
definitely. I'm glad you pointed all of those out. I did an episode on sleep, with Dr. Roger Schult, and he is quadruple board certified, and sleep is one of his board specialties. And we were talking about, light and exposure to light and how you want to expose your eyes to light early in the day, as early as possible, so that you're telling your body that it's daytime. And then at night, you want to avoid light. But it's like, okay, if you're avoiding screens and you're avoiding light, so that means you're not even reading with a light. I mean, you obviously have to have some light. So, uh,
Yeah, it's hard to take these broad rules into specific context, right?
right,
I have
exactly.
trouble with it myself.
Yep, yep, exactly. Okay, well, thank you so much for this great conversation. We will cover the last four letters of the acronym when we talk next. And in the meantime, I want to remind everyone that they can visit bendybodiespodcast.com to submit their questions, because future conversations with Dr. Knight will be revolving around what you ask us about. So we will be covering some of your most frequently asked questions in some of the future episodes. And in the meantime, we will share a hypermobility hack with you. Do you have one for us, Dr. Knight, or uh, do you want me to share one?
Well, I think we covered a lot of ground today, which is excellent. And yeah, so a lot to be pulled from it. But I think it's come up in a couple of scenarios. Like we were just talking about sleep, for example, and physical activity. And we started the episode talking about physical therapy. And, a little bit is better than nothing. And as you said, movement is good. And as I like to say, I've stolen from my orthopedist, and this is my hack, is that motion is lotion, right? So keep those joints moving as you can, if you can.
Yeah, definitely, because we also need load on our tissues, right, in order to get stronger. So yes, motion is lotion, and we need to keep moving. If we want to move, right, we need to, as my Mayo Clinic pain doctor said to me many years ago, if you want to move, you have to keep moving. So,
Right. Love
and
it.
he was absolutely right about that. Okay, great. So that is a wrap for this episode. Dr. Knight, thank you so much for chatting with me again today, coming from the UVA EDS and Hypermobility Disorder Center. And are things going well there so far?
Oh, they're buzzing along as as active as ever, and it's great. I mean, that's what we're here for. We're here to help as many people as we can, and we've just got our IRB protocol launched, and so a lot of exciting things to do. We got our symposium coming up in April, so we'll share more about the Bendy Bodies podcast at that symposium. So yeah, a lot of activity here in Charlottesville, Virginia. Glad to say.
Fantastic. So we will have links to the symposium to get more information about that, and also the clinic, how you can sign up to be on the wait list, et cetera, and more information about Dr. Knight. So, well, thank you again for chatting with me today. I know that you're very, very busy, and I always enjoy our conversations.
My pleasure, Dr. Bluestein. I enjoyed it very much.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.